everybody, this is Mrs. Poindexter. We're going to hit some highlights of valvular heart disease and inflammatory disorders. We're going to kind of go through this quickly, and then I'll slow down in parts where I need you just to be able to take the time and pay attention and kind of focus, and I'll ask some questions as we go along just to hopefully guide you in the right direction. So first we have valvular heart disease. Remember, we're talking about the valves of the heart. They are basically what opens and closes in the different chambers of the heart, and it creates different types of pressure to basically help the heart propel the blood into the heart to bring it back in, out to the lungs, and then of course out to the rest of the body. So obviously when we think about in particular the left side of the heart, this is the side of the heart that's going to do most of the work, so you're going to see more valvular dysfunction on the left side of the heart with either the mitral or the aortic valve. Classifications, this is more terminology that you need to understand the difference between stenosis, or if you hear the word regurgitation, or insufficiency. Regurgitation and insufficiency should go kind of hand in hand, and you can see here the difference where the stenosis, you see the narrowing, so you're getting this excess pressure that is kind of causing some backup into the lungs, and making it very difficult to actually enter into the heart. Regurgitation, here what you're going to see is that when blood is emptying into the heart, that some of it is going to have some backflow since the valves aren't closing properly. So we're talking about the root causes. The way that I kind of think of it when you look at the congenital to acquired, whether it's degenerative, which is damage over time, rheumatic, as I stated in class. When you hear the word rheumatic, just think autoimmune. Just think that something has happened that the body is actually attacking itself. Or infective, endocarditis is going to be an exterior infection that invades the body. So way to think of it is aging, internal and external. So it's either by overuse, autoimmune, or an infection. Some risk factors: hypertension, especially with most cardiac conditions, is typically going to be a risk factor. Rheumatic fever, this is an untreated strep throat or scarlet fever. Infection, congenital, Marfan syndrome, it's a genetic connective tissue where you see elongation, so stretching, and then age. Expected findings of somebody with issue with their valve: they may have a murmur. You don't need to know the different types or how they're graded. Also too, like I said, the bulk of the work of the heart muscle is going to be that left side, so you're going to see more damage on that side, so you may see increased pulmonary artery pressure, left ventricular hypertrophy, decrease in cardiac output, which can lead to orthopnea, and paroxysmal nocturia dyspnea, and obviously fatigue. And here, just so you understand what those terms mean, is basically shortness of breath when laying flat for orthopnea, and then the paroxysmal nocturia dyspnea is shortness of breath that actually will wake somebody up in the middle of the night. I think I've said now since the very beginning that the most common is going to be left-sided valve damage. Along with the symptoms, patients may also be at risk of having atrial fibrillation, so make sure you understand If a patient comes in, if we're suspecting left-sided valve damage, if they are talking about having a rapid heartbeat, having palpitations, a thumping feeling inside their chest, also with some dizziness, sweating, chest pain, pressure, shortness of breath, anxiety. They get tired more often when they're exercising. They might even have episodes of syncope. These are going to be some of the symptoms, and obviously they're going to have to be ruled out. The problem with atrial fibrillation obviously is going to put a person at a higher risk for stroke. Some other disorders, mitral valve prolapse, where you can see here the valve itself has kind of arched. It kind of reminds me of parachutes a little bit. Most times people are asymptomatic, so if they are, typically there's no treatment. If somebody is symptomatic, a lot of it's going to be about reducing stress onto the heart, so that's going to be in form of hypertensive medications like beta blockers, all the way to using things that like calcium channel blockers that help with the chest pain and palpitations. But also, as a nurse, you need to educate your patient about cutting out caffeine and alcohol, because a lot of times these will exacerbate their symptoms. You need to educate your patients about reading over-the-counter drug labels, because, again, you don't want them taking medications. I think I mentioned in class pseudoephedrine, for example. It can cause some heart palpitations. And then obviously maintaining a level of function and managing the symptoms. Septal wall defects. This is going to be basically when there's an abnormal opening between the right and left side of the heart, which allows oxygenated blood to be shunted from the left side of the heart where there's greater pressure to the right side where there's less pressure. A lot of times most of these defects are congenital and will either be repaired in infancy or childhood. A patient that may have a PFO, this is a small atrial septal defect. And a lot of times it can go untreated until somebody actually has a stroke, either TIA or CVA. A lot of times what the problem is in this case is that if somebody doesn't have this defect, that a lot of times a clot may be filtered out in the lungs, but with an ASD, you can actually bypass the brain, bypass the lungs and actually go to the brain, leading to a stroke. Again, with this, atrial fibrillation can be common, which again increases the risk for stroke. A lot of times the closure can be done percutaneously, and a lot of times these patients will need prophylactic antibiotic therapy to just prevent infective endocarditis. Other disorders, we won't talk a whole lot about them, but with cardiomyopathies, big takeaways that you should know about them is that basically it's going to be a disorder where there's a problem either with a mechanical or electrical dysfunction of the heart itself. It's best detected by echocardiogram. A lot of it's going to have to deal with how severe the cardiomyopathy is. A lot of times, again, treatment is going to be least invasive with medication. A lot of times heart transplant may be needed if medications fail. And with most of the different conditions we'll talk about today, if it's causing strain to the heart, it's going to be a goal of decreasing cardiac workload. So basically, a person should start off with bed rest and slowly increase their activity to get a level of manageability. I think it's just important that you understand what different tests are and what they look at. So at least just be familiar with these terms, and also have a general idea of, if you hear echocardiogram, you should start thinking that, okay, it can actually look at function, look at if there's any hypertrophy, to what a chest x-ray does, for example. Medications, please make sure you are familiar with just some of the common diuretics. You're going to see these all the time, and you really need, before you leave med-surg, you should really be familiar with these three. So furosemide, which is Lasix, it's a loop diuretic. It can cause hypokalemia. HCTZ, it's a thiazide diuretic. It can also cause hypokalemia. Aldactone is actually a potassium-sparing diuretic, but typically should not be used with patients with end-stage renal disease. So your two common ones you're going to see are going to be Lasix and HCTZ. A lot of times HCTZ is first line for hypertension. But if you have a patient who is on one of these diuretics that are non-potassium sparing, they really need to be educated about consuming foods and drinks that are going to be high in potassium. This is going to be everything from broccoli to avocados, dried fruit, nuts, spinach, mushrooms, things of that sort. Also understand too that low potassium can potentiate dysrhythmias. Some other medications that you should be familiar with, and this is a great slide to have because I'm giving you how the different cardiac meds end. So if you see something that ends in pril, you should know it's an ACE inhibitor. Your ARBs end in sartan, your beta blockers end in LOL, and your calcium channel blockers will end in dipine, basically. What these medications do is just basically help the heart pump easier just by altering the resistance. Because again, like I said, the valves and the heart all kind of work based on resistance and pressure. So it basically will help reduce that load that the heart must actually eject against. So it doesn't have to work as hard. Digoxin is an intratrope. Big thing is just make sure that you can educate your patient about self-administration and be able to know the signs and symptoms of toxicity. So if you look at some of these different signs and symptoms, if you break it down, I think stomach, eyes, and breathing. However you want to approach it, to make it a little bit easier for you to remember, go that route, but this is how I kind of remember it. With digoxin, you need to watch your patient's potassium levels, especially in states of low potassium. Toxicity can actually worsen. Anticoagulants are going to need to be used for those patients that have mechanical valves, so it's going to be lifelong treatment. The big problem with that obviously is because the body detects the mechanical valve as foreign, so that's basically the reason behind the long-term anticoagulants. So some invasive treatments, you don't need to necessarily know the ins and outs of these, but have an understanding. If you hear balloon valvuloplasty, you should know right away that it's basically being used to treat stenosis and it's going to be opening up a valve. Obviously, as you can see how this procedure is done, that it makes sense with the different complications. Anytime they're anything going up through arteries, there's always going to be risk for perforation, regurgitation, clotting, damage, rupture. So that's going to be kind of the downfall with that. But obviously the flip side is dealing with the stenosis. Other treatments, depending on what the problem is, to treat regurgitation, you're going to look at annuloplasty, leaflet repair, and chordoplasty. As I mentioned before, with the valve replacement, mechanical will need lifelong Coumadin, so make sure you understand your PT and INR. Tissue valves, on the flip side, you don't need those lifelong anticoagulants, but as you can see here, they need to be replaced every 7 to 10 years. Education for clients with valve issues is to basically kind of stress the importance of prophylactic antibiotics, especially if they've had valve replacement. Follow their prescribed exercise regimen, reporting excessive weight gain of either 3 pounds in one day or 5 pounds in a week. Talk to them about energy conservation, reading over-the-counter labels, reporting particular rashes or shortness of breath. Teach them about the symptoms of heart failure, and also fevers that can't be easily managed with Tylenol typically need to be reported as well. And again, restrict caffeine and alcohol intake. You're going to need to focus a little bit more time on your inflammatory disorders. Students sometimes can buckle under the pressure of taking tests and kind of get some of these inflammatory disorders mixed up with each other. So as you go through it, some of my advice is, especially when you're looking at signs and symptoms, see what differentiates it from the other inflammatory disorders, but also to think of what section of the heart is actually being affected, and a lot of times it can help you in terms of understanding treatment and complications. So again, itis means inflammation. Anytime there's an inflammation to the heart, it's just an extended inflammatory response that can lead to the destruction of healthy cardiac tissue. So that's basically the main problem of why when a patient has an inflammatory process that we want to try to kind of derail it as soon as we can, because as long as the inflammatory process continues, damage will continue to the cardiac tissue. So sometimes, depending on the actual inflammatory disorder, some of it's going to be through health promotion and disease prevention. Early treatment of strep infections are going to be very important, because noncompliance can evolve into rheumatic fever. And again, when I say rheumatic, you should think autoimmune. Okay, so untreated strep can lead to rheumatic, or untreated scarlet fever, which is basically a strep infection with a rash, can result in rheumatic fever. Basically what happens at this point, that the immune system starts to actually attack the healthy tissues in the body, that particularly of the heart. Prophylactic treatments will be needed, which can sometimes help prevent infective endocarditis, especially in those patients who have already had either some kind of valve damage, valve replacement, or some other heart conditions. It may be recommended, but that will vary per provider. Also, health promotion in terms of those who are at higher risk, especially those in the elderly population, to have both their flu and pneumonia immunizations. And this will help decrease the incidence of myocarditis. So some risk factors can be anything from a congenital heart defect to just lower socioeconomic status. So immunosuppressed, IV drug users, valve replacement are all going to put somebody at a higher risk. So the first one, pericarditis, this mimics the symptoms of a heart attack. When we talk about the pericarditis, it actually has 3 layers, and what we need to actually focus on is the space between the 2 layers. This is where a lot of the symptoms are going to come from outside of just the inflammation itself. So it's the pericardium. A lot of times it may happen following a respiratory infection, and sometimes it can be due to MI, which, a lot of times is difficult to navigate if a patient's already had an MI, because since the symptoms are so similar, they obviously may show up to the emergency room believing that they're having another. But findings that I have in purple here is where you're going to kind of focus on as part of your assessment of a patient coming in. It's going to be chest pressure, pain that is aggravated, especially when they breathe in, cough or swallow. They may have a pericardial friction rub at the left lower sternal border, shortness of breath, fever, but a lot of the pain may be relieved when they actually are in a tripod position. Anytime there's an inflammatory response going on, elevated ESR or CRP can show inflammation in the body. CRP is going to be much better for when there's a acute stage of inflammation going on. Also, with pericarditis, when you hook them up to an EKG, that they will have elevations. The ST segment will be elevated in all leads. And again, an echo will show the inflamed heart layers. Treatments will kind of depend on the cause. We always want to reduce the inflammation. As a nurse, like I said, if we are ruling out some other things, but suspect pericarditis, putting a patient in that tripod position will be helpful. Reduce our activity, provide a calm environment. Unfortunately, what is going to be difficult is with the inflammatory process and there being a space, it actually starts to build with fluid, and so a pericardiocentesis may need to be conducted in order to take pressure off the heart. So the 2 major complications that we're going to have from pericarditis are going to be effusion, which is basically fluid that will build up in the pericardial sac, and that buildup of fluid then leads to the second complication, which is going to be cardiac tamponade, and this is basically when there's compression of the heart from fluid buildup. As you can see here, basically it's putting a squeeze on the heart, and if you continue to squeeze the heart, what you're basically left with is that the heart is basically unable to function. So understand the signs and symptoms of cardiac tamponade: tightness in chest, restlessness, pulsus paradoxus, tachycardia, muffled heart sounds, and sometimes a JVD. As we move through the layers, going from the outer to now the middle, which is going to be of the myocardium, and this is going to be the actual heart muscle. This is a part that it's known as. This is when there's going to be inflammation of that heart muscle. The etiology can vary. It can be anything from viral to a inflammatory disease like Crohn's. When you're looking at these findings, there are a lot that are similar to the pericarditis. However, pericarditis mimics a MI, where myocarditis it doesn't, but because we're talking about the actual muscle, you may see some cardiomegaly going on, some dysrhythmias, because again we're dealing with the actual bulk of the muscle. Treatment is going to be relative to the cause. And what you may see in addition to some others is, again, since we're dealing with the actual muscle, which dictates the rate in which the heart is trying to pump blood throughout the body, that the addition of ACE inhibitors or beta blockers may help with any congestion and improve the overall cardiac hemodynamics. Biggest thing we have to be worried about, again, since we're talking about the muscle, is ventricular arrhythmias. Rheumatic endocarditis. So I've said it a few times, when you hear rheumatic, you need to think at some point the body is actually attacking itself. The cause isn't, it isn't like an outside force coming in and actually causing the damage. What happens here is you're going to have a bacterial infection that has invaded the body. It hasn't been treated properly, or it goes on too long, or the immune system just decides to turn on itself. But what it does in trying to attack the bacteria that has actually invaded the body, it unfortunately starts to damage itself. So it's just going to be a complication of rheumatic fever. So rheumatic endocarditis paired up with rheumatic fever, and it does cause permanent damage. This is going to be usually by the group A beta hemolytic streptococcal pharyngitis. So strep throat scarlet fever turns into rheumatic fever, which left untreated, rheumatic endocarditis. When we're talking about endocarditis, we're talking about this innermost layer here of the heart. Fever, since we're talking a little bit more about autoimmune and rheumatic, you're going to, some of the signs and symptoms that have differed from the myocarditis and the pericarditis are going to be rash on the trunk and extremities, muscle spasms, and those are kind of the two big ones. So rheumatic endocarditis, again, treatment through promotion. Health promotion is going to be about proper use of antibiotics, finishing that course. NSAIDs help with inflammation. Any other medications if patients are having signs and symptoms of heart failure. Sometimes they may need long-term to possibly lifelong antibiotics to prevent future attacks of rheumatic fever, because again, remember, rheumatic endocarditis is a complication of rheumatic fever. And unfortunately, depending on what kind of damage is done, it can also cause damage to valves, so valve replacement may be necessary. So infective carditis, this is just going to be an infection that stems from some other bacterial, viral, fungal, some other organism that has invaded the body and actually attacks that inner lining of the endocardium. So this can be, it's more common in those with some malformations, pacemakers, prosthetic heart valves, or IV substance abuse. And again, how people can get an infection can be anything from dental procedures to tattooing, any route that can introduce bacteria into the bloodstream. And this just kind of gives you a visual of how that happens. The symptoms for infective endocarditis, remember from Jane: fever, raw spots, ossular nodes, murmur, Janeway lesions, anemia, nail bed hemorrhage or splinter hemorrhages, and emboli. And this kind of gives you a visual that you can kind of remember, and just some brief descriptions of what they look like. Treatment is obviously prevention is best, especially those that are higher risk. If it is suspected, you need to get blood cultures to determine the most effective antibiotic. And this is the key part here, is that these individuals will need several weeks of IV antibiotics. This isn't like a 10 or 14 course. It's going to be IV antibiotics. It's not going to be pills. It needs to be IV. Complications: it can cause destruction to the heart and other organs. Cerebral vascular complications like stroke, valvular dysfunction, and first, second, and third degree heart blocks. Here's a visual of infective endocarditis, if you like this kind of visuals. And I'm just going to allow you to read through these questions and go through them again if you so choose. I hope you don't think that I fell asleep at the switch. I hope you were able to pause those, and I hope I gave you enough time to kind of read through those questions. But does chest pain always mean heart attack? I hope you said no. And I hope you immediately thought, well, pericarditis can cause chest pain and make someone think they're having a heart attack. But really, it's not that they're having a heart attack. Pericarditis, it can cause a squeeze on the heart, of fluid buildup and tamponade. That's why you feel that way. And I will put you in a tripod position to hopefully help relieve some of your pain. That's really what I hope you thought. So, again, Friday, looking forward to seeing you all again. And I know you're looking forward to the weekend. And most definitely, I know you're looking forward to the end of the semester. You've put in a lot of hard work. And I can tell you, it is not over yet. Take care.